Hello everyone, my name is Peter Cantillon. I'm a general practitioner and I'm also an academic at the university in Galway, which is the National University of Ireland in Galway in Ireland. I am very grateful for the opportunity to talk about a word like compassion, albeit that when I was asked to talk about it, I realised quite quickly it's not a word that I use very commonly either in my work as a GP or in my work as an educator here in the medical school. It's a word that perhaps comes from my past. I can remember growing up as a Roman Catholic in Ireland, it was used a lot in church. Priests would talk from the pulpit about the compassion of Christ, etc., but I never really understood it. Words I use with students tend to be words like empathy or altruism, understanding, mindfulness, etc., but never compassion. It seems to me to be such a challenging term. And in many ways, I suppose I would regard it as a nice idea, but hard to teach and hard to live up to. So I suppose it means to me, the meaning is to suffer with. And indeed, it's related to a desire to alleviate the suffering of others. Or perhaps using the Christian motif of do to others what you would have them do to you. Interestingly, when looking this up, I realized that it has a common origin with the term patient, which means the one who suffers. And thus I am indeed trying to be with or suffer with the one who suffers. We often use the word empathy, but of course now I realize it is something different. It's about an ability to understand or feel what another person is experiencing from within that person's frame of reference. And that for me remains a daily challenge in my work as a general practitioner, is to really put myself in that other person's frame of reference. And perhaps that's where I want to start then, is by saying that perhaps the word compassion is a grand aspiration of the medical profession, a standard that we aspire to, a cloak that we wrap around ourselves, but that, if we're honest with ourselves, is really hard to deliver on. Because self-care and self-interest get in the way. So I find myself, I don't know about you, but I find myself at times saying, thank goodness this is your problem, not mine. Now, how compassionate is that? Or, you know, in a busy general practice, and it can be busy at times, you're the 26th person I've seen today. I'm tired. And I don't feel like reaching out so much right now. I also, struggle with the notion of maintaining my self-esteem, my sense of competence as a health professional. So I'm not very compassionate when patients challenge me. They're angry with me. They want things that I can't deliver or that I don't think are appropriate. Then I'm forced into very different states of mind and I'm hardly compassionate. So I also think that being compassionate as a professional competes with other tasks that are going on in my head at the same time, such as what's going on with you? How can I make sense of what you're telling me? How do I strategize with you or indeed apart from you about what's best and in your best interest? I'm also concerned about the clock on the wall. I'm concerned about the patients who are waiting outside and are wondering why we're still mulling on in here about something and being compassionate. It clashes also with other discourses that I know are apparently important, such as me being right or being quick, being accurate. I graduated in 1983, and I graduated probably into a very different discursive environment than the current graduates come into. I graduated at a time where doctors were thought of as dispassionate persons, calm, unflustered, apart. In fact, the very donning of a white coat seems to separate that apartness and indeed a claim towards a scientific otherness. That detachment aids logic and aids my reasoning capacity. Therefore, I'm not cluttered with your smells, your feelings, your sweat, your thoughts. I'm over here thinking what's best for you and indeed what I'm going to do about it. I was graduated as a caring scientist with my coat buttoned up to my neck. But in my first week as an intern, as a resident, junior resident, I remember being on a vascular ward. And I was going around talking to patients who either had lost their limbs or indeed were about to lose a leg or a foot. And I was talking to them about stopping smoking because, of course, they all smoked. And one of them said, "Do you think that I don't know that smoking is bad for me?" Yeah, I'm still smoking. There's an ashtray there, because in those days you could smoke on wards. But do you not understand what it is to be addicted? And of course I didn't. I had no idea. I couldn't suffer with, because I had no idea what his reality was. I've never been addicted to anything, and I still amn't. So how on earth can I possibly be compassionate to somebody when I don't fundamentally understand what he or she is going through? So that was an example perhaps of where a patient was really teaching me something that medical school hadn't. And so it has proved to be for the rest of my life. It's interesting though that as a medical student there was a particular teacher that I remember, and he wasn't cool because he was passionate. He was red-faced and excited about things. He got us to do an exercise that lives with me still. He was an obstetrician. He got us to write about how we felt after the first delivery that we ever saw. Now that is not an uncommon exercise. And of course I gushed over 4 or 5 pages about how extraordinary it was, how courageous the mother was, how extraordinary the father was, what an amazing moment it was to be present at. I was a privileged participant. But then he got us to write about the 10th delivery that we witnessed. And that ran to half a page and is much more technical and talks about the speed of the delivery, the acceleration of the delivery, the chemicals used, and the mother hardly features. The child hardly features. The father, I'm not sure he was there at all. It was a very good demonstration for me about my journey away from the immediacy of being a privileged participant and therefore compassionate towards being a scientist and a part, and therefore a warning. It was a wonderful warning about what was happening to me as I was exposed to case after case. And I stopped seeing the particularity of each person, and I started to see people as, oh, one of those. So I suppose my journey since then has been a journey back towards maybe trying to achieve some shared understanding with patients about what's going on with them, a journey from the head to the heart, metaphorically. And indeed my own life experiences have been hugely important, so becoming a parent or having someone close to me go through divorce, or indeed watching the movie Trainspotting, which was an extraordinary exposition of the lives, the real lives of heroin addicts. And indeed all of this showed me about the power of narrative, of shared experience, of overlapping tracks between my life and others that helped me to really step into their space, be empathetic, which is a small part of being compassionate. It gave me also a more nuanced idea of what medicine is and can do or not do. I think now that medicine, a truth about medicine is that the emperor has no clothes and that we can't fix much of what comes to us, and that the doctor-patient relationship needs to be seen much more as a partnership, and indeed that patients are not really people who suffer. Yes, they do, so do I, but they're persons. Very much persons, and are as interesting and fascinating as persons really are, just like I am. So I don't perhaps compare as much as I used to, I don't judge as much as I used to, and I try to situate people. But as I said a minute ago, other things get in the way, like time, money, my own selfish needs, my own need to stay feeling competent and in charge. And yet, being more compassionate, I'm inspired by people's heroism, because when you think about the person as a person and you think about what surrounds them and what limited opportunities they may have or whatever, and you see them rising above it, then they are heroes. And part of my job is maybe to make them aware of that. So if we think about some ideas that maybe now are creeping into my work as an educator with students and new graduates, the first thing I think I need to do is move away from what I'm doing now, which is rhetorical argument, seeking to convince others about my point of view, because they're not ready for that. Partly because of life experience or lack of it, and partly because the imperative of passing assessments and getting over hurdles, and partly, of course, of their need to impress me. They are in a game of impression management, just as I am at times with patients. So how do we get over that? Well, one is to go back to that idea from my red-faced obstetrician role model and say that maybe it is about getting people to somehow really reflect, be mindful in the technique that he used, a reflective technique, getting me to write a sort of pre-post reflection, look and then wondering at my journey and what had happened to me and what effect that might have and how I might mitigate that. We also use, and many schools do, what I might call out-of-body experiences. Experiences where we try and, by taking medical students through events or experiences that take them out of themselves and out of the discursive environment of the curriculum and passing assessments and impressing me. And we use, for example, devised theatre as a technique to address features of the hidden curriculum, and indeed challenges of transiting from one state of student to another or graduating. And students do wonderful things with devised theatre that really help them to really live and be in this experience of the patient, or of doctor-patient relations, or indeed of themselves in their states of transit, or navigating the complexities of hidden curriculum. We also, a wonderful colleague of mine invented a simulated diabetes experience where students for a week take on the role of being a type 1 diabetic. They go through and have to use a diabetic diet. They have to inject themselves twice a day. They have to take blood tests 4 times a day, and they come out of that quite moved, and certainly, I think, potentially empathetic, if not compassionate, about people with type 1 diabetes. It is using the imagination like that and placing students in situations of genuine, perhaps discomfort, that might help them to begin to empathize, given their own relative lack of experience. We also use increasingly patients as educators. I can think of a mother, for example, who has had a very powerful effect on me and who teaches medical students, who lost her own son to medical misadventure, but through her own compassion for the professionals who looked after her son and seeing the error of their ways and their own blind spots, she's now worked out ways of helping us to be more compassionate and more aware of our own fallibility. So, to finish, I would like to say thank you for giving me the opportunity to talk about a word that I almost never use and that I perhaps would have rejected from my own Catholic past. But now I would say, it's one that I will keep certainly in my background when I think about how I plan and engage with students, and indeed bear in mind when I'm on my 27th patient and I'm trying to stay focused on what I'm really there about, being compassionate. Thank you.